Welcome to the Deep Dive. Today we are stepping into the orthopedic biomechanics lab to really get under the hood of one of the biggest success stories in modern medicine, the total knee arthroplasty, or TKA. I mean, for anyone in musculoskeletal care, this procedure is just a benchmark for success. It reliably cuts down pain, it gives patients huge improvements in function,
It really does.
and that success has pushed us to do it on younger, more active patients. And they come in with, really high expectations, sometimes maybe unrealistic ones.
And that's the core tension, isn't it? As surgeons, we absolutely celebrate the TKA. We see the phenomenal quality of life we can give back to people.
Right.
But as, scientists and engineers of the human body, we have to face this undeniable biomechanical truth. The TKA procedure, it inevitably and irreparably alters the knee's complex native geometry.
That's a strong way to put it.
Yeah.
Irreparably.
Well, it is. We are removing this finely tuned system of bone and minutiae and all these intricate soft tissue interactions, and we're replacing it with manufactured metal and plastic parts. It is, mathematically speaking, just never truly normal again.
That's such a crucial distinction. We get the clinical success, but we're accepting this profound biomechanical compromise.
Exactly. And our mission today is to really zero in on that compromise. We're going to dissect the contact mechanics research, pulling a lot from the work of pioneers like Sharma, Komistek, and their colleagues. We need to get past just saying the knee feels better and really understand precisely where the motion fails and why the forces can spike.
I think your analogy from when we were prepping really captures the spirit of this perfectly. You said it's like replacing a highly sophisticated suspension system.
It really is. I mean, imagine you've got a Formula One race car. Its suspension has been custom tuned for incredibly subtle handling, high performance.
Right.
Then you come along and you replace their entire system with heavy-duty components you've stripped from, like a farm truck.
A farm truck.
Right.
Now, the farm truck parts are reliable, they're durable, they will never break, and they'll get you to the finish line, no question.
Yeah.
But all the subtle, responsive handling characteristics that define high performance, gone forever. And that is the absolute essence of the TKA compromise. You get durability and function, but you lose all the finesse.
That frame really clarifies our focus for today then. We are looking at the core dichotomy of TKA, kinematics versus kinetics.
Right. So kinematics is the study of movement. It tells us how the TKA is moving. Does it roll back properly? Does it rotate? This is the direct reflection of what the patient perceives as function. Can they squat down smoothly? Does the knee feel natural when they walk?
And kinetics is the flip side, the study of forces. So this is the analysis of the load and the stress that the components have to bear. The structural side that really dictates the implant's longevity, its wear patterns, and the ultimate risk of mechanical failure.
Exactly. To truly understand TKA success and failure, you have to master both. So let's start by defining how we even measure these incredibly subtle movements and massive forces inside a living, breathing human body. When you start reviewing the research for an elective rotation like this, the very first thing that jumps out at you is that collecting in vivo data on TKA patients is just inherently difficult. You're dealing with this immense intersubject variability. I mean, every knee has a slightly different alignment, different scarring, a unique pathology history to begin with.
It's the classic orthopedic black box problem.
Right.
We need these methodologies that can somehow see through bone and tissue to track the micro movements of metal on plastic, all while it's under physiological load.
Right.
So the research really breaks down into two camps, in vitro lab testing and in vivo, which is live patient data.
So in the lab, that in vitro testing using knee simulators, that's got to be essential for developing new components.
Absolutely. They're great for screening new designs, for modeling how soft tissues might influence things, and this is the crucial part, for evaluating wear and trying to predict longevity. They are, the proving ground for durability.
But there's a catch.
Right, there's a huge limitation. Those simulators, they have to rely on standardized protocols. So standardized working cycles, standardized flexion paths. And while that's necessary for good comparative science, these protocols, they often just fail to simulate the actual highly variable operating conditions that the implant sees inside the body.
So like a patient suddenly pivoting or catching themselves on a stair.
Exactly. That creates a load scenario the standardized lab cycle just completely misses. And so we risk optimizing these incredible designs for a theoretical lab test, not for real life.
And that just emphasizes why in vivo methods, that live patient data, that's the real gold standard for clinical relevance. You mentioned that historically the most accurate measurements came from some pretty invasive techniques.
Oh, yeah. We're talking about methods like Roentgen stereophotogrammetric analysis, RSA, where you'd implant these tiny tantalum beads into the bone.
Wow.
Or you'd use bone pins and external fracture fixation devices just to anchor the measurement trackers. And these gave us exquisite, sub-millimeter accuracy of component movement, but ethically.
Yeah, you can't really ask a patient to go through that.
You can't. Asking a patient to endure invasive hardware just for a research measurement, it quickly became untenable. So we had to pivot to non-invasive options. And in doing so, we had to accept that we'd sacrifice some accuracy for patient safety and, frankly, the feasibility of recruiting people for studies.
So on the non-invasive side, we've landed on two major techniques. First one is skin marker technology. We see this all the time in gait labs, right? Markers all over the skin to track high-speed movement.
It's fast, it's cheap, but it's plagued by one enormous physical problem: the soft tissue artifact.
The skin moving.
The substantial relative movement of the skin over the underlying osseous structures. Imagine drawing a coordinate system on a balloon, and then you squeeze the balloon. The lines all move. That skin marker is very often not tracking the bone it's supposed to represent.
So how do researchers even begin to mitigate that? I remember reading about something called the point cluster technique.
Exactly. You have to use these pretty sophisticated correction measures. And the point cluster technique is one of the main ones. So instead of just one marker, you use a cluster of, say, 3 or more markers that are rigidly fixed to a plastic base, and you tape that to the skin.
Okay.
Then you have to develop these algorithms to mathematically track the relative movement between those markers and try to filter out all the noise from skin stretch and shear, all in an attempt to estimate where the underlying bone's pivot point actually is. It's effective, but it adds a lot of complexity and potential error.
Which brings us to the truly non-invasive gold standard for the kinds of activities we really care about in TKA slow speed, weight-bearing stuff like rising from a chair or a deep squat, and that's medical imaging.
Correct. Specifically, fluoroscopy, either single plane or, for higher fidelity, biplane systems, or even open and closed MRI. But fluoroscopy is key because it lets us capture the motion of the metal components under real, dynamic weight-bearing load.
And then you couple that with what's called 2D to 3D image registration.
That registration process is the real genius behind it all.
How's that work?
So you take a static CT scan of the components in the patient's bone beforehand, creating a perfect 3D model. Then you use these algorithms to match the outline, the silhouette of the 2D fluoroscopic image you took during the movement to that 3D model. And this lets you accurately track the component's position and orientation in all 6 degrees of freedom throughout the movement. It gives you incredibly reliable kinematic data.
Okay, so kinematics solved. Now for the really hard part, the kinetic challenge. Measuring the force. Position is hard enough, but trying to measure the massive internal force magnitude and direction, the joint reaction force, that just seems astronomically difficult.
It is, and it requires these specialized, extremely limited telemetric knee implants.
The instrumented knees.
Exactly. These are actual TKA implants that have been customized with sensors, microprocessors, telemetry coils, all to measure and transmit force data axial shear rotational moments from inside the joint out to a receiver.
I remember seeing pictures of those. They really do look like something from a spy movie. They must cost a fortune.
They do. We are talking high-cost, customized research instruments implanted solely for data acquisition. And because of the astronomical cost, the complexity of the surgery, the limited battery life of the internal sensors, and all the specialized post-op care, they're just not feasible for large-scale studies.
Right.
You might get incredible data from, say, 10 or 20 patients, but you're never going to get it from a population of thousands.
So if we can't reliably measure force in vivo across a whole population, that inherently forces us back to the computer, to computational modeling. Why is modeling the lower limbs so mathematically complex? Why can't we just plug in the geometry and solve it?
Because the system is indeterminate.
Indeterminate.
Think about it. You have a knee joint. You know the external load gravity, body weight, and you know the joint reaction force, which is the output we want. But that joint is held together and moved by dozens of muscles, ligaments, tendons, all pulling in different directions.
So you have more forces than equations.
Exactly. We have far more unknown forces, the individual tensions in each muscle, than we have fundamental equations of motion from Newton's laws to solve them. More unknowns than equations. So it's mathematically impossible to find a single unique answer without making some pretty big assumptions.
Which gives us the two main paths, optimization or reduction. Let's start with the hard way, the optimization technique.
This is where we try to find the best possible solution out of all the mathematically feasible answers. We use an optimization routine to minimize some kind of suitably chosen objective function.
So, like, we assume the body is trying to be efficient in some way.
Precisely. We might hypothesize that the body wants to minimize total muscle force, or maybe minimize muscle fatigue, or maybe minimize the joint reaction force.
Wait a minute. If the objective function is the key, and we don't actually have a consensus on what the body's really trying to optimize.
You've hit on it. That's the crucial caveat. A mathematically correct solution, a solution that successfully minimizes the function you chose, may not be physiologically correct at all.
I see.
If you optimize for minimizing overall stress, but the human body actually prioritizes minimizing metabolic energy expenditure, your model's results just won't reflect the forces the patient is actually generating. This lack of consensus on the objective function is why optimization modeling is still so challenging.
So how do researchers know if a mathematically optimal solution is just wrong physiologically? What's the test to tell the difference?
The test is comparing the model's results to those rare, expensive telemetric implant measurements we just talked about.
So you need the real-world data to validate the model.
You have to.
Yeah.
If our model predicts a quadriceps force of, say, 2.0 body weights during gait, but the telemetric implant study shows it's actually 3.5 body weights, we know our objective function is just plain wrong. It's this iterative, expensive, and frankly frustrating process of validation.
Which explains the appeal of the other route, the reduction technique, the simplified path.
Yes. Here, we just introduce simplifying assumptions to make the system determinate. For example, we might assume that certain small, stabilizing muscles contribute zero force, or we might group a bunch of muscles into functional units. We're just reducing the number of unknown variables until the number of unknowns equals the number of equations.
So that gets you faster, simpler solutions.
It does, but at the cost of fidelity. By forcing the system to be determinate, you get speed and simplicity, but you severely limit the number of physiological variables you can accurately determine. I mean, you can't determine the force of a muscle you've just assumed is inactive.
Okay, so finally, let's talk about the specific computational tools that handle the localized stress once we have the forces figured out. The gold standard for simulating material failure and wear seems to be finite element analysis, or FEA.
FEA is absolutely indispensable. It takes the geometry that we've segmented from a CT or an MRI scan, it applies the calculated forces and boundary conditions, and then it divides the components into thousands of these tiny interlinked elements. Then we can use linear and nonlinear FEA to model contact stress, strain, and predict wear damage.
And since TKA components are standardized, they have these regular predictable geometries like elliptical surfaces, there are specialized algorithms for them, right?
Yeah, that's a small technical advantage for modeling TKAs. Since the contact surfaces are often regular, you can use these specialized, faster algorithms like Hertz contact models, elastic foundation models, and explicit FEA. They let you calculate the contact mechanics on the polyethylene insert much more efficiently than if you were trying to model the full complexity of native cartilage.
So we're moving toward virtual wear simulators.
That's the goal, actively moving toward creating complex virtual wear simulators using these adaptive finite elements, hoping we can predict an implant survival before it ever even hits the market.
Okay, so we know how to measure the system. Now we need to define the system we're actually trying to replicate. The normal tibiofemoral joint is a 6 degree of freedom articulation, which just means it can move in 3 translations and 3 rotations.
But we simplify it, really, recognizing that flexion extension, internal-external rotation, and anterior-posterior or AP translation are the dominant movements. These 3 motions are coordinated into what we call the normal kinematics. It's this beautiful asymmetrical dance that allows for efficient, deep squatting.
So let's walk through that. Starting at full extension. In the early stages of flexion, say less than 10 degrees, the femur internally rotates relative to the tibia.
And then as weight-bearing flexion increases, the critical motion happens. The femur begins its posterior femoral rollback. And importantly, this rollback occurs with some slip. And at the same time, the femur externally rotates relative to the tibia.
That external rotation is what lets the knee lock in extension and then unlock to flex. But the mechanism of that rotation, that asymmetrical dance, is just fascinating.
It's the engineering genius of the knee. The axial rotation is driven by the fact that the lateral condyle moves considerably more posterior than the medial condyle. The medial side, for all intents and purposes, stays relatively immobile. It acts as the pivot point for the whole rotation.
And why is the medial side so constrained like that?
It's the soft tissue constraints. Anatomically, the medial collateral ligament, the MCL, is shorter and tighter than the lateral collateral ligament, the LCL. And that structural difference means the medial contact point is restricted in its posterior movement. And that forces the rotation to happen around an axis that's much closer to the medial condyle. The body is essentially making sure the big rolling wheel, the femur, tracks efficiently on the tibial platform by tightly controlling the medial side while letting the lateral side have greater freedom.
So we get maximum rotation happening early,
Yeah.
and then the deep dive occurs. What happens when patients push it go beyond 140 degrees of flexion?
The dynamics change again. The back of the thigh and the calf start to collide. We call this thigh shank contact.
Okay.
And this physical impingement actually influences the tibia to move a little bit anteriorly relative to the femur, which in turn forces both femoral condyles considerably posterior on the tibial plateau. This is why if you look at the geometry of a knee in a maximum squat, the lateral femoral condyle can sometimes be right at the very posterior edge of the tibial plateau.
Yeah.
The soft tissue contact helps drive the motion deeper and stabilize it.
Now that we get the tibiofemoral rotation, we have to recognize how that spinning motion directly impacts the crucial relationship between the patella and the femur, the normal patellofemoral mechanics.
Oh, that rotation is absolutely vital for patellar tracking. If the femur doesn't externally rotate correctly, the patella gets forced out of the trochlear groove. That leads to instability, tracking issues, pain.
And in a normal knee, it always stays in contact.
In a normal knee, the patella always maintains contact with the femur throughout the entire range of motion. But the contact area changes significantly.
Right.
Up to about 90 degrees of flexion, you generally have a single contact region. But as you move toward high flexion, beyond 90 degrees, the contact areas actually divide into two distinct regions. That reflects how the patella seats into the deepest bunks of the trochlea. And by 135 degrees, the stress often involves the odd facet of the patella, which is this small, rarely contacted area on the lateral side.
All right, let's pivot to the normal kinetics, the forces. The movement during a deep knee bend is powered mainly by the quadriceps. And the research shows this kind of counterintuitive three-region force pattern during a squat.
This is a classic example of biomechanics just fighting intuition. So region 1, from 0 to 90 degrees, the force generally increases, which is what you'd expect, right? You're fighting gravity more.
Makes sense.
Region 2, from 90 to 120 degrees, the force hits its peak. And then here's the surprising part. Region 3, beyond 120 degrees, the required force actually starts to decrease.
That is highly counterintuitive. I would assume the deeper you squat, the harder the quads have to work. Can you walk us through the moment arm effect here and explain why that required force goes down at high flexion?
We're talking about leverage. The moment required to hold the position is the force applied by the quadriceps multiplied by the quadriceps moment arm. That's the perpendicular distance from the rotational center of the joint to the line of action of the quads tendon.
So a bigger moment arm means less force needed.
Exactly. An increase in that moment arm means you need less force to generate the same moment. And the moment arm is influenced by two opposing factors based on the joint geometry.
Okay, the two factors are the quadriceps angle and the condyle location.
Precisamente. From 0 to 90 degrees, as the knee flexes, the angle of the quadriceps tendon relative to the tibia decreases. That tends to reduce the moment arm, making the muscle less efficient. However, at the same time, the femorotibial condyles are moving posteriorly. That's our posterior rollback. And that posterior movement tends to increase the moment arm.
So in that initial 0 to 90 range, those two factors are kind of fighting each other, and they mostly just offset the moment arm effect, which allows the muscle force to increase as the external demand increases.
But here is the critical biomechanical switch that explains why the force drops at the peak. Once you get into that 90 to 120 degree range, the quadriceps tendon starts to physically wrap around the distal femur.
I see.
Once that wrapping occurs, the angle of the quads relative to the tibial plateau stays relatively constant. Therefore, the factor that now dominates is the continuous, albeit slower, posterior movement of the femoral condyles.
And if that posterior movement increases the moment arm, then the required force has to decrease to maintain equilibrium.
Exactly. The farther back the condyles move, the greater the leverage the quadriceps gains. The body is leveraging that posterior position to achieve and stabilize deep flexion more efficiently. The peak force hits around 90, 120 degrees, and then because of the improved mechanical advantage from posterior rollback, the required muscle force drops off substantially. And this natural blueprint is the entire focus of TKA design. So if the normal blueprint is all about posterior rollback and that asymmetrical movement to gain leverage, then the TKA compromise is really defined by its failure to replicate this.
Hmm.
I mean, while normal knees can hit 160 degrees or more, modern high flexion TKAs are designed for around 155. And the clinical reality we often see is maximum flexion hovering somewhere between 90 and 120 degrees, even in technically perfect surgeries.
And the research confirms that the in vivo kinematics are just fundamentally flawed compared to the natural knee, even in that 0 to 90 degree range where patients spend most of their time.
The failures are specific and they're repeatable. First, and I think most destructive, is the paradoxical anterior slide of the femoral condyle, often the lateral one.
So instead of rolling back, it slides forward.
Exactly. Instead of rolling back and gaining leverage, the condyle slides forward relative to the tibial insert as the knee flexes. This actively reverses the moment arm efficiency we just spent all that time talking about.
That is the definition of fighting the physics of the joint. If you slide forward, you lose your leverage, and the quads have to work harder.
Correct. Second big one, we see low axial rotation. Because many TKA designs force a near symmetrical rollback, the medial and lateral condyles move posteriorly by similar amounts, and that just negates the necessary asymmetry you need to drive external rotation. It makes the knee feel stiff or non-compliant.
And related to that, sometimes we even see these perverse reverse axial rotation patterns, where the femur actually rotates internally relative to the tibial component with more flexion, the complete opposite of the natural unlocking mechanism.
The final two failures are really structural outcomes. Condylar liftoff, where one condyle completely loses contact with the polyethylene insert, causing localized point loading, and persistent patellar instability and abnormal tracking, often because of improper axial alignment that the TKA component just can't accommodate.
To really dig into the consequences of these kinematic failures, let's dive into that important case study by Sharma and his colleagues from 2014. They directly compared 250 high flexion versus low flexion TKA patients using dynamic fluoroscopy.
Yeah, this is a key paper. They divided the TKA patients into two groups. Group 1 was the low flexion patients max flexion of 95 degrees or less, and Group 2 was the high flexion group max flexion between 110 and 130 degrees. And they tracked the component position throughout a deep knee bend.
The key kinematic finding here, which I think is often missed, is the position of the condyles. We should probably define the terms from the study for you, the listener. MAP is the medial AP position, the anteroposterior location of the medial condyle, and LAP is the lateral AP position.
And what the data showed was just startlingly clear. In the high flexion group, Group 2, the MAP and LAT of both femoral condyles were significantly more posterior than in the low flexion group, Group 1. And that was true at every single common flexion angle they studied, 0, 30, 60, and 90 degrees.
Wait, so you're saying the ability to achieve high flexion isn't necessarily dictated by how much rollback the TKA achieves during the squat,
Yeah.
but by where the condyles start and remain relative to the tibia throughout the whole motion?
That is the critical interpretation. Think of it like a sprint. The high flexion patients weren't necessarily faster over the 100-meter course, but they started 20 meters ahead of the other group.
I like that.
Their overall posterior starting position, which is likely influenced by soft tissue balancing and component rotation during the surgery itself, that gave them the inherent advantage in leverage from the very first degree of flexion.
So if the surgeon sets the implant and balances the soft tissues in a way that lets the femur start more posteriorly, the patient is essentially optimizing that quadriceps moment arm right out of the gate.
Precisely. The overall posterior position is the predictive factor. And this is further validated by the non-significant findings from the same study. When they looked at the amount of translation, the L-trans and M-trans, and the amount of axial rotation, or AXROT, between the two groups from 0 to 90 degrees, the numbers were not statistically different.
That is the ultimate kinematic nuance. The high flexion patients didn't necessarily move their condyles more during the functional range. They just occupied a position that was mechanically superior, more posterior than the low flexion patients. They leveraged their position, not just their movement. It's the difference between a farm truck trying to drift versus a race car that's already hugging the corner apex.
And now we transition from movement to load. Because if the TKA fails to utilize that optimal posterior leverage, the patient has no choice but to compensate by generating significantly more muscle force to achieve the same motion. And that means the forces on the implant just spike.
The researchers quantified this by comparing the axial femorotibial contact forces in those TKA groups against normal knees. The The first finding, I mean, it's immediately visible in the data, was the enormous variability of contact forces in TKA patients.
That variability itself is a failure. Normal knees show a relatively tight cluster of force magnitudes across a population. TKA subjects, on the other hand, showed forces ranging wildly, and this higher variability is likely due to the massive differences in individual soft tissue tension, alignment, and the muscle strength compensation patterns people develop.
And the magnitude differed too, especially at high flexion.
Yes. Beyond 90 degrees, right when the normal knee gains maximum leverage and the force naturally dips, the TKA forces remain stubbornly high. The data showed the average maximum axial contact force reached about 3.0 BW, or body weight, for the better performing high-flexion TKA patients.
And what was it for normal knees?
It was significantly lower, about 2.4 BW for normal knee subjects.
Wow, that's a 25% increase in the average peak load compared to a native knee. And that's even for the TKA patients we would consider successful in terms of their range of motion. What does a 25% increase in peak load mean for the longevity of the implant?
It's exponential for wear. Wear is not a linear thing. It's highly dependent on the contact stress, which is just force divided by area. So if you increase the force by 25% and the contact area simultaneously decreases, which we often see in TKA, the cumulative wear damage just accelerates rapidly. It means a faster path to osteolysis and eventual failure.
And consistently across both of the TKA groups, the research showed the medial side experiencing higher contact forces compared to the lateral side.
This is a really robust finding, and it validates what we see clinically. When we look at retrieved implants, we overwhelmingly see evidence of more medial wear. The medial side of the TKA continues to bear the brunt of the load, which suggests inadequate load transfer to the lateral side, possibly due to persistent varus alignment or just suboptimal soft tissue balancing.
So connecting this back to the kinematics, if the high flexion patients start posterior, does that translate to lower forces across the board for them?
It does, even in that 0 to 90 degree range. The high flexion group, group 2, tended to exhibit lower total femorotibial contact force than the low flexion, group 1, across that common range. This is the kinetic proof of the kinematic finding. Superior positioning leads directly to lower force demand.
We also have to consider the anterior-posterior, or AP, contact forces, the shear stress. These are particularly concerning in a TKA because the implant has to rely on the constraints built into its own geometry rather than the patient's own ligamentous stability like the ACL.
And the shear forces are dramatically higher. I mean, the data in figure 20.6 synthesized the finding that AP forces were significantly lower in normal subjects than in TKA subjects at any flexion angle they studied. This tells us that the TKA system is constantly dealing with higher shear forces, which often puts the polyethylene insert at risk of delamination or crete failure over time.
And finally, the statistical knockout punch linking movement and force. The locations of the femoral condyles were found to be highly correlated with the contact forces. They reported a massive correlation coefficient of 0.86.
That 0.86 is the number to remember from this deep dive. It proves that our hypothesis that position determines leverage, which in turn determines force, is statistically robust. Normal knees, by maintaining more posterior condyle position at high flexion, utilize the geometry of the moment arm to naturally reduce force magnitudes.
So the clinical takeaway is all about rollback.
The clinical takeaway on forces for designers is that the primary goal isn't just to allow rollback, but to ensure that the component interaction facilitates and maintains that asymmetrical posterior femoral rollback lateral condyle, moving more posterior than medial, to decrease constraint and reduce those contact forces. This leads us directly to the design problem. We need components that reduce these dramatic forces we just discussed, but we have to do it without inhibiting the necessary motion. This is the design war. The constant trade-off between conformity and laxity.
Conformity. So how tightly the polyethylene insert matches the femoral condyles, that reduces stresses and theoretically enhances longevity.
Right.
But laxity, the relative freedom of movement, that's what accommodates the normal kinematics and prevents the force spikes. The designer is just stuck between a rock and a hard place.
Completely. The three factors that ultimately dictate your contact areas and stresses are critical: the radii of the mating surfaces, the relative component alignment, and the contact forces themselves, which cause the surface to deform. We are trying to engineer a solution that the body naturally achieves through irregular geometry and compliant cartilage.
The researchers compared 6 common implants, contrasting posterior stabilized, or PS designs, which use a post-cam mechanism, with posterior cruciate retaining, or PCR designs, which use the patient's own PCL ligament, often with components that have asymmetrical condyles to encourage that natural rollback.
So let's look at the contact area analysis first, comparing the sigma fixed bearing PS and the sigma rotating platform PS.
Okay, so the rotating platform, or PPS, maintains significantly higher contact areas on both the medial and lateral condyles compared to the fixed bearing design. Why did simply allowing it to rotate help spread the load so much better?
Well, the rotating platform mechanism allows for axial rotation of the polyethylene insert relative to the tibial tray, whereas the fixed bearing is, cemented or fixed rigidly.
Got it.
In the fixed bearing, if the femur rotates, the contact area shifts dramatically, and that reduces your load-bearing zone. The RP, because it can rotate along with the femur, ensures that its more conforming geometry is always correctly aligned to the load. It's constantly optimizing its position to maximize contact area, spreading the force over a larger region and thus reducing stress.
I see. So that ability to move constantly ensures compliance. It's like a perpetual self-aligning mechanism. However, the general trend for those Sigma PS designs was a decrease in contact area with increasing flexion, especially on the lateral side.
Yes, that decrease suggests that as the knee flexes, the component interaction struggles to keep the surfaces fully mated, which leads to potential edge loading. And interestingly, only one design in the whole study, the NKII congruent PCR, showed a significant increase in contact areas with increasing knee flexion.
That's a major anomaly. What structural feature of that NKII congruent PCR drove that increase?
Its geometry is designed specifically to capture the femoral condyles and actively guide them into that posterior position using asymmetrical surfaces. This allows the femoral component to really seat deeply into the polyethylene as flexion progresses. This deep seating and capturing mechanism, while it might limit ultimate rotation a little, it maximizes the contact conformity at the most demanding angles. It's a clear attempt to improve durability.
Okay, now let's move to the intensity of the load. Contact stress analysis. The general trend was that the average contact stresses increased with increasing flexion, which makes sense, right? The force is spiking and the contact area is often decreasing.
And here again, we see the dominance of the medial side. Medial contact stresses were consistently higher than lateral contact stresses across all the designs, which correlates directly with the clinical data showing more medial wear in explants.
But despite these high stresses, the key finding for implant survival is actually encouraging. TKA designs generally maintain enough contact area to keep the average contact stresses below the yield strength of the polyethylene, which is typically around 20 to 25 megapascals. That's our safety buffer against catastrophic material failure.
It is our ultimate protective measure. But this returns us to the fundamental design war. We need conformity to keep the stresses low, but if we make the components too conforming, we inhibit that asymmetrical rollback, which causes the forces to spike the kinetics, which in turn increases the contact stress anyway.
It's a vicious circle.
It's a vicious circle where optimizing one variable quickly breaks the other. We're trying to build a farm truck that can handle like a race car.
Which, based on all this data, leads us right back to the original tension. We can make it durable, but we just can't fully restore the complex asymmetrical movement dynamics of the native knee. #outro.
So, to synthesize this entire discussion, the key mechanical lever in successful knee function, both normal and implanted, is the posterior movement of the femoral condyles. This asymmetrical rollback leverages the quadriceps moment arm, which reduces the required muscle force, which then translates directly to lower femorotibial contact forces. And this explains, both physiologically and statistically via that 0.86 correlation, why the high flexion patients in the Sharma study start and remain in a significantly more posterior position.
Mission success confirmed. We've really unpacked the difference between kinematics, the failure of motion characterized by paradoxical slide and reverse rotation, and kinetics, the failure of force, which is evidenced by these dramatically higher axial and AP forces compared to normal knees, especially at higher flexion.
And future TKA design, it hinges entirely on mastering that perfect equilibrium. We need components that actively facilitate posterior rollback. The lateral movement has to significantly exceed the medial movement to reduce the overall joint forces. But at the same time, we have to maintain enough conformity in the polyethylene to spread that unavoidable load and keep the contact stresses safely below the material's yield strength.
Which brings us to our final takeaway for you, the learner. And it ties right back to our initial discussion on computational modeling. We established that these complex optimization techniques still struggle to achieve physiological correctness, right? They often yield solutions that just don't match reality.
Right.
So considering that really strong 0.86 correlation between the condyle location and the contact forces, are we maybe overcomplicating the design process?
It's a fantastic question. Perhaps we are. If the position of the condyle is such a powerful, reliable predictor of force magnitude, maybe we should stop trying to calculate a minimum generalized force using these complex, assumption-ridden optimization routines. And instead, maybe we should prioritize replicating the exact posterior condyle location and tracking geometry that we observe in high-flexing normal knees. If we can solve the kinematic positioning problem empirically by focusing on that critical 0.86 correlation, the kinetics, the forces might just fall into the optimal line naturally. Sometimes focusing on the simple, proven physiological mechanism is better than chasing the mathematically optimal but physiologically elusive answer. Something to mull over until our next deep dive.